Gastrointestinal bleeding. Gastrointestinal bleeding can be of two types, hematemesis and melena. Hematemesis means vomiting of blood, and melena means when blood comes out with stool. So there will be passage of black tarry stool which contain altered blood. Causes of upper GIT bleeding are the following. There may be bleeding peptic ulcer, which can be gastric or duodenal ulcer. There may be gastric erosion. There can be rupture of esophageal varices, which means esophageal dilated blood vessels can be ruptured. There may be esophagitis. There may be malformation in the vasculature. There can also be Mallory-Weiss tear, which means the lower esophageal tear which occurs due to violent coughing or vomiting. And it can be associated with the cancer of stomach and esophagus. While taking the history of upper gastrointestinal bleeding, we should consider the following facts. We should take if there is presence of history of peptic ulcer because it can lead to the diagnosis of bleeding peptic ulcer. There may be history of NSAIDs, example aspirin intake, which can cause gastritis and peptic ulcer. There may be history of alcohol intake, which lead to Mallory-Weiss tear. There can be previous history of jaundice and liver disease in case of rupture of esophageal varices. In stomach carcinoma, there can be history of weight loss, abdominal lump, and old age. We should consider the color, smell, and consistency of stool to see if melena is present or not. During clinical examination, we should examine for features of shock such as pallor, cold peripheries, tachycardia, and low blood pressure. If anemia is present, and if stigmata or marks of liver disease such as jaundice, spider nevi, which is swollen blood vessel or telangiectasis beneath the skin surface, ascites, and splenomegaly, we should see if there is presence of comorbidity such as CCF or congestive cardiac failure, ISD, ischemic heart disease, renal failure, liver disease, or metastatic cancer. We should do a investigation for full blood count because chronic or subacute bleeding may lead to anemia. We should see the urea and electrolyte levels and do liver function tests. We should also check prothrombin time if there is suggestion of liver disease or in patients who are in anticoagulant therapy. We should check the blood group and cross-match to resuscitate the patient and do upper gastrointestinal tract endoscopy. Treatment options are immediate treatment and subsequent treatment. In immediate treatment, we should do intravenous access to give electrolyte and fluid. We should give blood transfusion if there is presence of shock. Example is there is shock due to when pallor, cold skin, systolic blood pressure is below 100 mm mercury and pulse is above 100 beat per minute. We should give oxygen therapy. If patient is in shock or have liver disease, we should do urgent endoscopy for endoscopic thermal modality such as heater probe, or to give injection of diluted adrenaline or epinephrine into the bleeding point, or to apply metallic clips. Then we should continue to monitor pulse, blood pressure, and urine output. We should re-endoscope for if bleeding or hypovolemia is continued. If this bleeding persists, even after endoscopy, or rebleeding occurs once in older and or frail patient or twice in younger or fitter patient, we should try surgery. The subsequent treatments are treatment of peptic ulcer, then control of portal hypertension if bleeding occurs from esophageal varices. The patient should avoid alcohol, and NSAIDs should be taken properly along with proton pump inhibitors.